Hi, good afternoon. I hope you can all see my screen.
Yes, we can.
Okay. So my name is Dr. Jeffrida Chepchumba. I think the moderator has already said my qualifications. So I'm going to present on the policy perspectives and priorities for childhood cancers. So I'm the program officer in charge of treatment, palliative care and survivorship at the National Cancer Control Program, which is a program in the Ministry of Health under the non-communicable diseases department. So okay, so on the outline of my presentation, we'll start with the introduction, the overview of childhood cancers, the WHO Global Initiative for Childhood Cancers, the Kenya Cancer Policy Environment, the e-learning platforms, the way forward, and conclusion. So the International Childhood Cancer Day, which is today, is a global campaign used to raise awareness about childhood cancer. And this is because childhood cancers have some unique needs, and it's also used to express support for children and adolescents with cancer, the survivors, and their families. So it's celebrated on the 15th of February each year, and it started in the year 2001. So the theme for this year is better survival through your hands. And this pays tribute to the healthcare team and how they are essential in ensuring better survival for the children. So globally, we have over 400,000 children diagnosed with cancer each year. Local data is still not confirmed, but we know over 70% of these 400,000 is actually in the lower and middle income countries. But what is appalling is actually how the survival rates differ in the low and middle income countries compared to the developed countries. So in Kenya, you'll find about 19% of children will be cured of their cancer, as opposed to the developed countries where 80% of these childhood cancers are cured. So you can see it's a big gap, a very big gap. And this is a big area that we'll need to check into. And some of the factors that have been brought forth for this disparity is lack of awareness and information on childhood cancer, delayed or wrong diagnosis, lack of access to quality, cost-effective essential medicines, lack of access to trained health providers, weak health infrastructure, obstacles to accessing healthcare, abandonment of treatment, death from treatment toxicity. And I think out of all these reasons, we can say maybe where the healthcare workers can come in the most is the first, let's say, 4 points or 5 points. So we need to create the awareness and information on childhood cancer. In terms of diagnosis, we understand that diagnosis is only possible at certain levels of care of facilities. So at whatever level of care you are, you can still assist with the diagnosis. And this is by having a high index of suspicion. If you see certain symptoms are recurrent, you refer the patients to the specialized facilities. Also, in terms of the weak health infrastructure, we are seeing maybe the referrals are not done in good time, or maybe there's just some lack of knowledge of where to refer. So such systems we need to align. So most of the childhood cancers can be categorized into three. Cancers of the blood, will have the brain tumors and the solid tumors. I won't dwell on this because we have a pediatric oncologist on the call. So the causes of childhood cancers are generally unknown. They are unrelated to lifestyle, and most cannot be prevented or screened for, because you'll find even children as young as 3 months may be presenting with some symptoms. So since we cannot prevent it, we need to be highly vigilant when a child is coming for the clinics. If a child is coming for any other symptoms, maybe for flu symptoms or abdominal issues, we need to really fully evaluate this child. And the main point of this slide is actually that most childhood cancers are highly curable if detected early, hence the importance of a high index of suspicion among healthcare workers. So the WHO initiative for childhood cancers, this was launched in 2018 with the aim to improve the outcomes for children with cancer around the world. So the WHO is hoping to give children the best chance to survive, to live full and abundant lives, and to live and die without suffering. And this will be done by increasing the country's capacity to provide quality services for children with cancer, prioritize childhood cancer nationally, regionally, and globally to spark action. So as I had mentioned before, the survival rate for our country is around 20%, yeah, give or take. And the goal by 2030 is to achieve at least 60%, which will be a big boost compared to the developed countries which are reporting 80%. And if we do this, we'll actually have saved 1 million additional lives. So we can all contribute to this. So the initiative calls for focus on 6 common cancers, which represent 50 to 60% of all childhood cancers. And these diseases are highly curable with proven theories. And these include the acute lymphoblastic leukemia, Burkitt's lymphoma, Hodgkin's lymphoma, retinoblastoma, Wilms tumor, low-grade glioma. When we come locally to our country, these are the cancer policy documents that so far have been launched, and they provide a framework for cancer control. And you can see the Kenya Cancer Policy 2019 to 2030, the National Cancer Control Strategy 2017 to 2022, the screening guidelines, and the treatment protocols. All these and more documents are available at the MOH website under resources, then you go to downloads. So when we move to the National Cancer Control Strategy, Strategic Objective 3.5 indicated that we need to optimize treatment and palliative care for childhood cancer. So this included the organization of existing treatment facilities to incorporate pediatric cancer treatment and supportive care services. This is still ongoing. We are yet to fully reorganize the services, but it's work going on. Also, we needed to advocate for pediatric chemotherapy and adjuvant formulations to be incorporated in the KML. This has already been done as of 2019. Advocate for adoption and finalization of evidence-based treatment protocols. As I had mentioned before, one of the documents we've launched is actually the national treatment protocols. We also need to provide services for palliative rehabilitation and survivorship of for children. This is ongoing, and in my next slides, I will indicate how far we've reached in this area. So another major objective of the treatment protocols was to improve standards for treatment and care for those with cancer. So when the treatment protocols were launched in 2019, this outlined the 10 priority cancer groups, including pediatric cancers. Then the dissemination was planned to start in 2020, and due to the COVID-19 pandemic, this could not be done because of the restrictions in movement. And this is when we sat down with the stakeholders in the health space, and we decided to do the dissemination virtually. And this was done through conversion of the content from the protocols into a web-based platform. And also this was developed into a mobile application called Sarasani. And the content was also uploaded to the MOH Virtual Academy. I hope all of us have heard of the Virtual Academy. So this content is the 10 priority cancer groups, and you have an assessment for each type of cancer. And on top of that, you get CPD points, and certificates are downloadable upon completion. So the overall goal of this platform is actually to downstage cancer cases, because if the primary healthcare workers are able to have a high index of suspicion, they will start referring patients in good time, as opposed to managing recurrent symptoms. And by the time you're referring, we are seeing a lot of stage 3 and 4, and we all know the poor outcomes associated with this. So the first e-learning platform, as I mentioned, is the Sarasani app, and this is found on the Google Play Store. And you can find the content here is very relevant, it's comprehensive, and it's self-paced. So it's at your own pace. You can decide to do a chapter per day, and yes, yeah. And the target groups for these platforms includes the medical doctors, the clinical officers, the nurses, and the pharmacists. The MOH Virtual Academy, you can find this, if you just Google MOH Virtual Academy, you can also find it. So this is a web-based platform. You can use it mostly on your laptop or on your computer, and you find there are many other health-related resources. So what we did is that we added an early diagnosis of cancer course for primary healthcare. And the same features apply. You have the questions, you have the assessments, and you have the CPD points and the certificate. So it's a very good platform. So on the way forward, as a ministry, would like to encourage that the NHIF cover for children needs to be tailored to suit their needs. The quality and standards of care, we need centers of excellence to be established to just guide the care for children with cancer. Also, we'd like to encourage more clinical research into childhood cancers to inform best practice. Also, to increase access to rehabilitative commodities and treatment assistive devices. And this will come with also development of the guidelines for rehabilitation of children. And a big part is also the sociocultural issues surrounding childhood cancers, the stigma, the reintegration into the society, because we are aiming at 60% survival rate. So this means the child will have to be reintegrated into the society. And due to certain issues, sociocultural issues that the child may face, we need to actually address this both from the national level to the regional level, even to the schools. And we're actually involving the Ministry of Education in our TWGs to just assist us in coming up with these guidelines. So in conclusion, what we are saying is that better survival for children with cancer is achievable. The aim is to have 60% survival rates for children by 2030. And this can be done through having a high index of suspicion, yeah, and early detection, which can save lives. We need to tailor-make the treatment for children. And as we are aware, children are not small adults. So we don't just take their treatment and the adult treatment and maybe divide it into 2 or something. No, it needs to be tailor-made for the children. We are hoping to have a pediatric center of excellence to just guide management of childhood cancers, and also increase the number of pediatric trained specialists. This includes the oncologists, the nurses, and even the social workers, the psychologists, all those, they're essential. So thank you. Let's remember, better survival is achievable through your hands as the healthcare workers. Thank you.
Thank you so much. Thank you for that very concise and informative talk. I'm sure we are quite appalled by those survival rates, and we are going to see how to do better. Like you said, we need to have a higher index of suspicion and how to raise awareness. So I think Dr. Njuguna will be going next. Let's hear from him. If anybody has any questions for Dr. Chepchumba, please just put them in the Q&A section. Thank you.
Thank you very much. As has been mentioned, I'm Dr. Njuguna, and I work in Eldoret Moi University and Moi Teaching and Referral Hospital. So today we are talking about childhood cancer as we celebrate this important day. And has been mentioned, the theme for the International Childhood Cancer Day this year is better survival is achievable through your hands. So although the talk is supposed to focus on early diagnosis, I will mention several other things that I think are important in ensuring better survival of children with cancer. So I will highlight one or two things on epidemiology and then discuss pathways to care, which I believe is an important component in terms of increasing survival. And we'll talk about early diagnosis here and some of my thoughts about what we can do as a country to be able to achieve better survival of children with cancer. So we mentioned briefly through the previous presenter that there are about 400,000 children who are diagnosed each year with cancer. But the focus here of this map of the world should be on South Africa, where we can see 18.6% of all children who are diagnosed per year live within this area. So it means close to 1 out of every 5 children with cancer globally lives in sub-Saharan Africa, and that's where Kenya lies. So it means we have a big burden of the disease. And just to mention that although nobody has done a count of how many children got cancer last year or the previous year, we can actually be able to tell roughly the number that was affected, because we know the incidence of cancer globally, and there's not much difference between what it is in high-income countries or Europe vis-a-vis Africa. The incidence rate of childhood cancer is almost the same globally, and that is something close to 150 to 160 children per million children per year. So using that figure, it's actually possible to estimate that close to 3,500 or 4,000 children develop cancer every year. I think the big question is how many of them actually get diagnosed. And my thought is that probably less than 20% of this number get diagnosed. So we also mentioned that survival in Kenya is probably about 20%, but also just for us to think through the figures, that is 20% of the ones who are diagnosed. So if we actually thought about the true survival of those who get the disease, we'll find that we are dealing with a very low figure. And just to highlight that below 10 years, the commonest disease that is diagnosed is leukemia. And this is acute lymphoblastic leukemia and acute myeloid leukemia. And as we move towards the teenage years, lymphomas, and that is both the groups of Hodgkin's lymphoma and non-Hodgkin's lymphoma, together with the soft tissue sarcomas, start to predominate. So this is how we probably can think about the pathway to optimal childhood cancer care. that will enable us to be able to diagnose all those children that we mentioned and be able to have survival rates that are close to 80% like we have in the high income countries. So it starts with being able to recognize possible cancer, and this usually happens at the community level, and then being able to move to the primary healthcare facilities, being able to move to the tertiary health facilities, getting a diagnosis, getting treatment, and getting registered into a database that helps us to be able to monitor the treatment that we are offering the patients and being able to tell what our survival rates look like. So I'll mention a few things about each of these things. So like, for example, in terms of recognizing a possible cancer, this mainly is hinged on public awareness. We need to educate the Kenyan population that cancer occurs in children. We've had a lot of discussions, a lot of radio, TV programs about adult cancer. We need to put the same information out there, but children also get cancer. But although it is quite rare compared to adult cancer, it is still occurs. So that then we are able to increase this number of children who are diagnosed with cancer from 25% to closer to 100%. And we know there are many negative beliefs and myths that are associated with childhood cancer, and this plays a role in terms of getting children to the appropriate health facilities. Because once a family is told, maybe we think your child may have cancer, they may decide to go back home, go and seek traditional healing rather than go to the conventional health facilities. And this has a big impact in terms of getting the diagnosis and treatment and care for the children. So as a people, we can educate each other about childhood cancer by thinking about the early warning signs. And as has been said, it's not childhood cancers, we cannot go screening, doing mass screening, like for example, the way we can do for adulthood cancers, like breast cancers, where you do self-breast examination or mammography and things like that. In children, what we need to do is to be able to pick up early signs that may tell us this child may have a likelihood of having cancer. For example, children who present with pallor, bruising or bleeding, and bone pains. And this is something that commonly occurs in those children who have acute leukemia. They present with pallor because they become anemic, since their bone marrow is full of these abnormal cancer cells, and they cannot make the normal white blood cells, they cannot make normal red blood cells, and hence they become pale. They cannot make normal platelets, so they present with bleeding, they present with bruising. And because the bone marrow is so full of these abnormal cells, then they experience this bone pain. Bone pain could also be a manifestation of bone cancers, for example, osteogenic sarcoma or Ewing sarcoma. And it could also be a manifestation of a primary tumor elsewhere that has metastasized to the bone marrow. So that is one of the things that you need to see, and it may make you suspect that a child may be having the malignancy. So, and then the next thing is about lumps and swelling, which is quite common with childhood malignancies, especially if they say this mass has been growing over time, it is becoming bigger, and they may have weight loss, which we'll also mention about. They may be accompanied with fever sometimes, or even when they have fever, we may not be able to pick specific signs of infection. And these swellings may occur in the neck, for example, they may occur in the abdomen, and they may occur in the limbs as well. The other thing is unexplained weight loss. Somebody who has lost weight unintentionally over the past couple of months, and they also have fever at the same time. They present with what we call night sweats, and sometimes they may have shortness of breath or cough. this may be an indicator that they may have a cancer. So remember, this is also something that we also see in, for example, patients who have tuberculosis, they present with weight loss, they present with fever and cough. So it just tells us that, you may think of TB as the first thing, but at the back of your mind, always keep thinking about malignancy, and especially children with TB. Once we start them on treatment, in 2 to 3 weeks, the fever should be gone, their appetite should be increasing, they should be looking healthier. If that is not happening, then for sure, you need to start thinking about a malignancy. The eyes, usually we look for what is called leukocoria or white pupil. And this is usually a common thing that is seen in patients with eye tumors in children called retinoblastoma. They may also have a loss of vision and they may have a squint. And we normally say that any child with a new onset squint should be referred to an ophthalmologist. Don't try to treat a child with a new onset squint if you are not an eye specialist. It's better you send them to the ophthalmologist and then they tell you this is benign. But a new onset squint should be sent to an ophthalmologist. We've talked about abdominal swellings. We have quite a huge number of childhood malignancies that present with abdominal swelling, including Burkitt's lymphoma, including kidney tumors like Welch tumor, malignancies like soft tissue tumors, for example, sarcoma, which usually present with abdominal swelling that has been progressively increasing over the past few weeks or months. And sometimes causing symptoms, including vomiting, including difficulty in passing stool and things like that. Then headaches, usually a sign of brain tumors, especially if persistent, severe, and if they cause vomiting. This should make us worry about malignancies. And this is headache that has been there for a number of days and sometimes weeks, not a headache that has been there for 1 day. And then we talked about limb pain in association with leukemia, but this can also occur in bone malignancies as well. And if you see these symptoms and they've been there for a number of weeks, you need to think about childhood cancer. So these are things that even the general public will be able to understand. These are things that community health workers can be able to understand, the nurses in all our health facilities, the doctor. So especially when you have a combination of more than one of these things we've mentioned about, is your index for suspicion for childhood malignancy increases. So once you suspect that these are malignancy, then we need to talk about primary health facilities and what is their role. And this is mainly about making a clinical diagnosis that this is possibly cancer, and then thinking about what to do. But we know that there are several barriers that may, make one not be able to access the primary health facilities, including a cost of transport, being the distance from the health facilities. And we talked about health beliefs as well. But the key thing in the primary health facilities is health workers' knowledge that they are able to have a high index of suspicion, and then they know the signs and symptoms that we have previously talked about. They'll be able to pick up these children and be able to give the right information and refer appropriately. And then the primary health facilities, we need to make use of some of the investigations. And what I can think about here mainly is what we call a full hemogram and an ultrasound. So many of our sub-county hospitals and maybe even the bigger health centers may have the capability to do full hemograms. And this will especially be important for acute leukemias, which constitute 25% of all the childhood cancers that we should see. And anytime you see a very high white cell count, a low hemoglobin, low platelets, or a very low white cell count, low hemoglobin, and a low platelets, that increases your suspicion for acute leukemia in children. Now, these are children who need to be referred for further investigations. Ultrasound, because it can pick abdominal masses and be able to tell you whether the mass you're palpating is arising from the kidney or is arising from the idiopsychical area, which may raise your suspicion for Burkitt's lymphoma. And then more importantly, for the people working in the primary health facilities and also the secondary health facilities, is knowledge of where to refer the patient to and who to consult in case they need more information about this. So knowing the people in your area who treat childhood cancer becomes important. So when they get to the tertiary health facilities, which in this case are the treatment centers, what are the needs there? We need to have personnel who can handle the patients. We need to have infrastructure for diagnosis. We need to have both diagnostic and laboratory facilities to be able to make the diagnosis. We need to have the capability to have microscopes that can be used for pathology, the capability for CT scans, capability for X-rays, that all together help in making the diagnosis. And then the other thing is about health financing at this level, whether the patients or the family are paying out of pocket, which is likely to have a negative impact in their adhering to the treatment and finishing the whole continuum of therapy. Whether they have insurance, we've mentioned the previous talk about the issue of NHIF, which we believe is very key and very important, that all children who have been suspected of have a malignancy should be enrolled in NHIF. But more importantly, we need to encourage all Kenyans to enroll into one form of health insurance or the other, because that relieves a lot of pressure on the families and in terms of paying for the costs. And also we need to leverage on donors that we may find may come our way in terms of pooling resources in financing the costs for treating cancer, because it's always an enormous burden. And then the availability of treatment options, including chemotherapy, including surgery, including radiotherapy, including what we call supportive care. That this need to be available in the tertiary facility for us to be able to provide appropriate care. So for you to get to the tertiary level facility, we need an efficient referral system. We talked about finances. Remember, the family has to stop working. Other children have to stop going to school for the child with cancer to be fully taken care of. And that is a big burden for the families. We need to deal with health beliefs, and we need to deal with the issue of communication by the healthcare providers, both at the referring facility and the tertiary level facility, so that the parents or the family know, even when they're being referred to the center, the urgency and the reason why they need to move to the other facility, not being merely told you need to go to the other hospital because we are not able to do this. We need to tell them we suspect your child may have a diagnosis, and time is of essence if we are to treat, so that we're able to reduce the time lag between the time you have symptoms to the time you have the first contact with the healthcare system, and also to reduce the time lag between that time when you get into the first health facility to the time you diagnose and to start the treatment. And all these things, which we have subdivided into the patient delay and the healthcare system delay, all have an impact in terms of the stage at which the patient presents, and that ultimately affects the outcome. So there are some factors that lead to patient delay, and as you can see, as shown in this blue line here, the patient delay, we have noted in our facility that it is actually shorter than the healthcare system delay. So as a healthcare workers, we actually need to be more proactive in the suspicion and referring the patients, so that we reduce the time length between the time the patient gets to us and when we start the treatment. The patient also have a role to play, but we have looked at this in several malignancies, and we know that it is a much shorter period as compared to the healthcare system delay. So just for us to know, some of the facilities that treat childhood cancer in the country at the moment include Kenyatta National Hospital, Teaching and Referral Hospital, Getfruits Hospital, Akan Hospital, Nairobi, Kenyatta University Teaching Referral Hospital, and Kijabe Mission Hospital, and maybe others. But it's good for us to be able to identify which hospital in our area treats these cancers and know how to refer the patient. And we mentioned about the diagnostic capabilities that we have in the country in terms of pathology. All the hospitals that treat childhood cancer should be able to do histology on a minimum, and other facilities may have the capability to do immunohistochemistry and other specialized tests like flow cytometry and cytogenetics. and radiology, including CT scan and MRI, which are now available in many facilities. And now we have a public health facility with a PET scan. And we also need biochemical studies to be able to add to our ability to diagnose these malignancies. And when we come to the treatment, just to mention one or two things, that it is either supportive or definitive, and you need a multidisciplinary team that will include many people, including pediatricians, surgeons, pharmacists, and others. And the supportive treatment is aimed at improving the quality of life, including counseling the family and the patient. We need to manage pain. We need to think about transfusing the children, preventing and treating infections, proper nutrition, and management of nausea and vomiting. Without this, even if you have the best chemotherapy drugs, you'll still not be able to cure the children with cancer. That is why it is important to mention about supportive care. Definitive care, be clear with the family why you are starting the treatment. Is it for curative or palliative intent? And then number two, be able to recognize and manage any emergencies that may occur, including cord compression, airway compression, and another one that we call tumor lysis syndrome. And then the best way to go about the treatment is to base the treatment on standardized protocols. So chemotherapy alone will cure majority of leukemias and lymphomas. For the solid tumors, you need chemotherapy plus what we call local control, which is either radiotherapy or surgery or both. And then there are several other therapies which are currently not very available in our country, including bone marrow transplant, immune therapies, and cellular therapies, which we hope will be available in the coming years. And the final thing is about data. It's good to have all this information put together. It will help us to monitor trends in diagnosis, and treatment, and the outcomes. And with this, then we can be able to make decisions in terms of the treatment protocols that we are using and the treatment strategies. Are they working or are they leading to a lot of deaths? And then we are able to use this information to talk with our Ministry of Health in terms of resource allocation, in terms of future planning, in terms of what areas should we focus on in terms of the treatment, and be able to benchmark with local and international standards when we have appropriate data. So we've heard about the global initiative for childhood cancer by WHO. And for me, I think this, if you looked at this as a country, we'll be able to, conquer childhood cancer. Because if you look at the approach down here in blue, the technical package, we need centers of excellence, and these centers of excellence should have care networks, meaning a center like in Nairobi should have a network of facilities within Kiambu, Machakos, and Kajiado, for example, which are working together with the center of excellence in terms of referring patients and sharing care. And we need to have a sufficient and competent workforce, as my earlier presenter mentioned. Financing, universal health coverage. I think this has been a big talk in the past few weeks, and we really need to talk about this. And more importantly, we need to have packages that are oriented towards childhood cancer. And then for the treaters, the doctors and the nurses, we need to have regimens for appropriate management, which should be guided by what is available, by the technology that is available, and what has been shown to work. And then using the data, we should be able to do proper evaluation and monitoring with the quality assurance and information systems. So for me, this is what we need to do as a country. And although I have highlighted here what I think should be probably the priorities, but the previous chart looks at it in a more comprehensive manner. That as a country, we need a national action plan based on the WHO initiative. And we should create funded centers of treatment for childhood cancer. These are the ones being called centers of excellence. So we should not just create centers, but we should have funding that comes from the national government that is geared towards the same. We need to inform our public that childhood cancer exists, and we need to have a better and more trained workforce. Thank you.
Okay, thank you very much, Dr. Njuguna. That was very interesting. And I think today the magic number seems to be 20%, because if we have less than, again, 20% being diagnosed, I think everybody saw that chart that was talking about the 7 warning signs for childhood cancer that they can use themselves as well as should teach others. So I hope you took a screenshot of that, everybody. And I think you put the honors on us, Dr. Njuguna. Now let's welcome Jennifer to give us her talk.
Thank you. As you have heard, I'm Jennifer Murabi. I'm I'm a nurse, a KNH-UoN nurse. I've done counseling and psychology, and I'm a pediatric oncology licensed, and working in Kenyatta National Hospital, Ward 1E. And I'm here today to share with you the advocacy of a child with cancer, of which I'll start with the role of an oncology nurse. And I'll also share what the nursing care which is given in the unit, the skills of an oncology nurse. There's also a grieving process and my perspective as by my experience. So we are going to start with the role of an oncology nurse in pediatric oncology. So nurses play a great role in cancer management. Majorly, pediatric oncology nurses help children and their families cope with the cancer treatment process, which is a very, very painful process, and it's a long journey which the parents and the patient, they need to work together with the nurse. Also, they assist the family to cope with the treatment process, which is not easy. The cancer treatment is a traumatic and upsetting event, for especially, it's a traumatic event such that it's an upsetting event, but a pediatric oncology nurse, her or his presence can provide comfort in otherwise stressful situation for the child. Children are too young to understand, cannot make own healthcare decision. Hence, they require additional coordination between the healthcare workers, patients, and families. Next slide, please. What is not happening?
Just give us a moment to rectify the presentation. I'm sorry for the delay.
Sorry for that.
Okay, Jennifer, I think we can continue.
Sorry for the itch. I think
Sorry,
we go to the
thank
next. Nelson, you go to the next slide, please. Next. Okay, we continue. An oncology nurse basically should be a very compassionate and a caring person. In order to take care of these children, must have that compassionate in her or him. And this one, in order to earn the family trust and give encouraging word when need be. It is for oncology nurse to strive to normalize child's experiences by reducing stress through distractions. When the child is going through the painful experience, there is always a lot which is done for them. So the nurse is able to distract the patient's attention, so that maybe by singing for them, there's play therapy, so that the patients can experience less pain. And this is also reducing stress through distractions. We support patients as they celebrate their smallest victory. You find when these children, what they undergo is a lot, they also have emotions, but when there is victory they earn, we normally support them and we celebrate with them. For example, when we accept their investigation reports, when the investigation reports, they come positive, they are acceptable, so for the treatment to continue, we normally just celebrate with them. When the patients just persevere and they manage to persevere, the frequent pricks, because they are always pricked every day, every now and then they get blood for investigations, they have to be pricked for IV line to be fixed, for other procedures to get treatment, to get blood transfusion. It's not an easy experience, but we have to encourage and celebrate with them so that they can accept and continue with the management. We support them also by persevering through the procedure, and also we grieve, the grief process during these loss. When they're grieving, also we are there to support them. There is also, we create time to instill fun, sharing laughter, and sometimes tears. Sometimes we have to be with them emotionally, we have to be with them. When it is good times, we just have to make fun, we laugh together, and sometimes we cry together. And there is also an issue of addressing visiting siblings and loved ones. They come when they're too emotional to see their younger ones suffering. So we have to be there with them, we address them, and we have to explain so that they can also support the patient to continue with the management. We also offer health education to families to aid in decision-making process. Sometimes you find people, even when the diagnosis of cancer has come, they don't understand what is going on and what is expected of them. And they even think that the child having cancer is a death sentence, which we have to talk to them, we have to explain to them, and we have to be sure that they have to make a proper decision for the management to continue. We also help them for the navigation to healthcare system, where to understand and to know how to go about it, how to go through the navigation until we get complete treatment. At times, we intervene in family conflict. In pediatric, is so different from adult, such that we find that sometimes when a child is diagnosed with the cancer or in chronic illnesses, the parents tend to blame one another. Sometimes they can say this is not from our family, it's from your family. From experience in between, some families break. So as oncology nurses, we make sure we work together, we explain to them it is not anybody's fault, so that they can understand and so that we can maintain that family unit together. And often we serve as an advocate for these families. Remember, it's a child, it's a holistic family. We take care of all the child, the parents, the guardians, and the loved ones. So we have to be advocates for all this, especially also the child who is our patient. We empower family through knowledge. We promote self-care and successful transition from hospital to home. For this child, when they start treatment, they often go home and come back. As they go home and come back, we have really to make sure that we have successfully transitioned these patients, this family, to know how to take care of this patient, both at home and in the hospital, and the importance of coming back for visits, taking drugs at home. All this has to be done very, very carefully with an oncology nurse. We ensure safe delivery of treatment as scheduled. They go sometimes they go home with these chemo drugs, which are very toxic. We have to explain how to give it at home, and in case how to monitor any side effect and how they will come back, in case what can make them come back, so that we can intervene in case of any side effect in good time. We also collaborate with the physicians in safe delivery of treatment, especially clinical trials, so that we can deliver and recognize any, in case of any symptom management which will arise, and we'll know how to deal with it. And we promote patients' comfort holistically. That means we have to make sure the patient is comfortable physically, psychologically, socially, and even spiritually. And we also provide patients and families information standards to pain control, because sometimes the pain is too much. So we have to really, as an oncology nurse, you have really to understand at a deeper depth about pain management, so that we can make these patients as comfortable, as pain-free as possible. We assist with the behavioral and the physical interventions of these patients. They stay longer in the hospital. And sometimes we play a role of a mother, a father, a pastor, so that we can make sure that the behaviors are well maintained. The physical interventions we do the personal hygiene, we make sure it's up to standard. We prevent and alleviate the side effects of pharmacological therapies, so that we observe and act in early enough, so that we can prevent them. We also promote patient compliance with the therapy and the requirement of any follow-up. We are always there for the patient. Next slide, please. We also, the nursing care also it also involves explaining the rationale for interventions and provide time for family questions, whereby when the families, when they have all the questions, they have all the concerns they have as per their children, we just have to address them, which includes the pharmacological agents, their side effects. We tell them how they can, which side effect they expect and how to come about it, the dosage of the scheduled drugs and when to give, the regime, and we also in the intervention to alleviate the other side effects like nausea and vomiting, like when to give antiemetics. In the case of constipation, how to go about it. All these we have to explain to them in a language which everyone will be able to understand. We monitor effectiveness of pharmacological interventions. We monitor the respiratory status, bowel functioning, as well as mental and cognitive functions, so that we make sure that this patient is doing well. The parents and the guardians are guided how to contact medical personnel in case of any emergency, and they should feel free to do it anytime. So when even they go home, you find that they have our contact, so that we can they can contact us anytime they feel like they should contact us. Next slide, please. Next. As a nurse counselor, I was feeling like that some areas needs to be acted on, so that we can do a better management for these patients. We can advocate better. Like in our pediatric department, we really feel like we need an navigator personnel who can help these patients to navigate through, because the hospital is so big. Sometimes the patient is sent to go and collect to go to a certain point, but they get lost in between. If a navigator personnel is found, it will really relieve certain duties from a nurse who is supposed to do more, who is supposed to advocate more to a patient than just navigating, where a job where somebody else can do. We can also recommend for a nurse counselor in each unit. Each unit of the oncology patients, they should have a nurse counselor who can really take through all this, the journey for these parents and the patient. And this will improve for the care of the patients. We also have skills for oncology nurse process, which we then, as an oncology nurse, they should have interpersonal skills, which is very, very necessary, where interpersonal skills, ability to remain patient and empathetic in stressful situations, and ownership of the work. A nurse should also have observational skills, whereby the process of sensory information, whereby you analyze and draw conclusions that improves job performance. For a child is not able to express, but oncology nurse can observe and conclude, and so that an action can be taken. We also have communication skills are very necessary, whereby interacting with, in order to interact with the colleagues, patients, families, you have really to have good communication skills. You have to be attentive listeners, share information in a positive yet an honest way. Also, emotional intelligence skills are very necessary, which will help to manage own emotions and interpret and respond to emotions of others. If you cannot manage your own emotions as a nurse, it's not, or as any healthy worker, it's very difficult to manage emotions of our patients. So when you have emotional intelligence skills, this really helps a lot. And this one will take us through even when a patient succumbs. It helps the health worker to grieve, personal grief, before you go to the families, and you prepare to help the next patient who needs care. There is also creative skills, which we have available resources that transform patients' experiences. Like patients are put sometimes to do the art and the craft, they draw, they do what they want, sewing, and some helps in relaxing the patients. In the process, we cannot talk of oncology nurse without talking of grief process, because we really need these steps of grief process in order to emotionally to grow and to continue, because we find that in grief, both the health personnel, sometimes they're feeling like, no, things are not right. The patient is feeling the same. The relatives are feeling the same. So we have all of us holistically deal with the grief process, which is the first. We find that when things has happened, here is a child who was sick, it has been diagnosed, now it's a chronic, it's cancer. People find that they denial. You deny, oh no, why not? Why me? Why not? Why this child? Why? When as you do that, it's a process. After you finish with that process, you have to deal with the anger, which you feel like you are so angry to God, angry to everybody why it happened. Then the next step, you start bargaining. Then you might go to depression and acceptance, or you can accept and still go back to denial. And that's why in the staffs, we have the staff supportive office, which supports staffs. When anybody where you are working, you feel you are so low, kindly seek support from the supportive staff supportive office. They will always help us. I have my personal remark, which was where, to me, working in oncology pediatric unit for a long time as just a general nurse and managing these patients, there were challenges, and this motivated me to train as oncology nurse, of which has given me better skills in managing these patients. And I feel that there's some gaps in the management where I recommend for patients. We find that there is none or poor navigation process, which is there. There is also inappropriate passing of information, especially when the child is diagnosed as cancer. Whoever breaks the news to that parent or to that child means a lot for the next management of these patients, because the way they get it, that date, they will never forget it from their life. There is also a challenge in breaking bad news, especially when a patient succumbs. How to go about it, I think we need more training on this. Also for staffs, we need more nurses. Some of the panelists have recommended, I also recommend, we need more nurses trained on oncology. People should be encouraged to join school. We also need more continuous medical education over the same seminars to know about chemosafe and other things. Sometimes we need team building so that we can relax from the emotions we have carried for so long. And the debrief sessions in the unit level, we thank God the supportive staff, supportive office, they do it every now and then, but we need it more and more. Next slide. Nelson. Next slide, please. Okay, he's not able to give the next slide, but I think I've done most of it. And above all, we listen and we care. And we remain to be advocates. Thank you.
Okay, thank you so much, Josephine, and thank you for being patient with all the technical hitches. I think you've given us a very interesting perspective on what your work involves and how much we actually need more nurses who are counselors, nurses who are oncology trained, because we have quite a large leap to go from the 20 to 60%. So I'd like to invite our final presenter to give us their talk. Dr. Wata. Welcome.
Good afternoon.
Good afternoon, Dr. Wata.
Yes, thank you for the invite. I'd like to just talk a little bit about pediatric oncology treatments and some of the challenges we have in terms of providing chemotherapy treatment for pediatric oncology patients. So I'll talk about, we'll have an introduction, the role of the oncology pharmacist, the challenges, the efforts we've put in, and the opportunities we have to push the agenda forward. So by way of introduction, I think what has been highlighted more in the media and even in most of our CMEs is the adult oncology, the medical oncology, and the clinical oncology. Pediatric oncology hasn't been given a lot of attention. It's important to note that pediatric oncology has its own uniqueness, that we are dealing with the children. And as Dr. Festus Njuguna had rightly said, children are not small adults. And this is especially in terms of the way we dose the medicines and the way they handle the medicine. So there are all these differences that come due to the fact that they are children. So the treatment regimens for children differ from similar conditions in adult oncology. So for example, if you look at acute leukemias, both adults and children are affected by acute leukemias, but if you look at the treatment regimens that are used, you'll find there are normally some differences. If you look at, for example, non-Hodgkin's lymphoma, the way it's treated in adults and the way it's treated in children, you'll find there are several differences. So you'll find that there are these many differences that are in pediatric oncology when you compare to adult oncology. And children may have differing response in terms of children may have differing response in terms of adverse effects of medicines. So the way they respond in terms of the side effects and even in terms of the treatment will be different from the adults. And also the dosing schedules tend to differ in pediatrics for some drugs. So you'll find that, for example, when you are treating rhabdomyosarcoma for the small children, for the infants, you will tend to use the dosing by weight instead of by BSA. If you're treating rhabdomyosarcoma in adults, you're using BSA, you're not using per kg weight. So you'll find all these differences that come because due to pediatric oncology as compared to the adult oncology. So it's important when someone is venturing into pediatric oncology to just be cognizant of all these differences so that they're able to be effective in what they are doing. So for the role of the oncology pharmacist in pediatric oncology, one is the chemotherapy preparation, the chemotherapy regimen and dose verifications. We have to verify the regimen according to the diagnosis and also the dose according to the diagnosis and according to the regimen. Then also supportive care management that Dr. Njuguna has talked about in terms of management of nausea and vomiting, management of pain, and management of other adverse events that may accrue due to use of chemotherapy. Then there's the medication use counseling, how the patients will use the medicines, especially those medicines that the patients will go with home, and multidisciplinary care. Now, some of the challenges that we experience in pediatric oncology will include medicine availability. Now, if you look at just generally in a hospital setting, most of the people who come to promote medicines, we are talking of the pharmaceutical companies, they'll tend to focus mostly on the adult oncology. So if you look at the oncology landscape, we'll talk about Herceptin, we'll talk about rituximab. Those are the medicines which will be heavily promoted. And because of this promotion, those are the ones that will tend to be pushed, and there'll be a lot of work, background work on these medicines to ensure that these medicines are always in good supply. But for those that will be specifically for pediatric oncology only, you'll find that there are challenges in availability. So here I'm thinking of 6-mecaptopurine that we use for acute lymphoblastic leukemia and L-asparaginase. In fact, if you look at the Pharmacy and the Poisons Board, you'll find that no one has retained or registered this medicine in Kenya, meaning that even the importation of this medicine will be with difficulty. And the other challenge is that, for example, if someone brings in a particular brand of asparaginase, you're not sure that they will bring the same brand the next time they bring it because they haven't registered it, meaning they don't have a contract with the manufacturer, meaning their ability to bring this medicine locally available is a bit wishy-washy. The other challenge is the complexity of regimens in pediatric oncology. For example, if you talk of non-Hodgkin's lymphoma, treatment mainly is by R-CHOP for most of the non-Hodgkin's lymphomas in adults, which is basically doing a medicine every 21, doing the regimen every 21 days. For pediatrics, if you're using the COPAD-M regimen, it's a bit complex to follow because it's different each time you're giving it. And then you have the thorny issue of NHIF. So the NHIF cover that we currently use was mainly suited for adult oncology regimens. It wasn't designed for pediatric oncology regimens. And so for this reason, the pediatrics tend to have the shorter end of the sticks when it comes to getting approval for their chemotherapy treatment. Then, as you know, we have less research in pediatric oncology, and thus there's a less number of chemotherapy medicine for pediatrics. So each time, if you go, for example, for an ASCO conference or for an ESMO conference, it's likely you'll hear of a new medicine that has been approved by the EMA or by the US FDA for use in a particular adult oncology treatment. If you go for a COP conference, this may not be the case. You won't find any new, maybe for the next 3, 4, 5 years. Then the oral medicines, as you know, most of them are formulated for use by adults. There are very few that are formulated for use by children. So for example, even locally, you won't find an oral syrup for chemotherapy to be used for children. So you can only talk of maybe prednisolone syrup, and that has been, and as you know, prednisolone is used for many other indications, not only oncology. But if you think of maybe something like methotrexate or 6-mecaptopurine or hydroxyurea, you won't find this in in a formulation that is suitable for pediatrics. Then the other challenge we commonly meet is what are called adult cancers in pediatrics. So for example, nasopharyngeal carcinoma or colorectal cancers appearing in a child. So these ones give challenges in terms of management, since you don't have too many documented cancers of the same. But so when they appear in pediatrics, then it poses a challenge in terms of management of the same. So some of the efforts we are making or we've made in terms of treatment. So we are trying to do some studies so that we can develop and validate some pediatric friendly formulations. So one for 6MP, for hydroxyurea, and for a few other things. So we are still trying to do the proposals and get the funding so that we'll be able to come up with some pediatric friendly formulations for these medicines that are specifically used by children. Then of course, engaging with NHIF so that they can understand the pediatric oncology regimens and therefore provide approvals for pediatric oncology treatments. Then also development of unit dose formulations that are parenteral for use for pediatrics. So for example, GCSF, which is used a lot in supportive care, both for pediatrics and for adults. What is in the market is mainly suited for adults. So we are trying to work on a way that we can do some unit dose formulations just for pediatrics so that they can get a unit dose that will suit only the pediatrics. And something that we're also working, trying to do here in KNH is development of chemotherapy roadmaps that we'll use for management and follow-up of patients. As we had said, chemotherapy for pediatrics tends to be complex, and therefore you tend to have missed doses, or for example, incorrect prescriptions when the patient comes in next for the chemotherapy. And we think that if we do the roadmaps, it will be able to solve these problems so that the prescriber knows what the patient got last, what their patient is supposed to get today, what their patient is supposed to get in the following time they come, and therefore plan for this chemotherapy much more effectively. So I think with this come to, okay, so we'll go to the opportunities. Some of the opportunities that are there are research, one, into the pharmacogenetics of the Kenyan and the African population. We know that some drugs like 6-mercaptopurine and vincristine, the enzyme that metabolizes them, there could be differences depending on the population. There could be that variation of differences, and therefore this will lead to a variation of response to treatment. And also just research into PK/PD studies for these medicines in our population. As you know, these studies that bring out the doses are done in the Caucasian population, and it will just be important to know if the Africans will express the same pharmacokinetics and pharmacodynamics the same as the Caucasian population. And there's also opportunity for advocacy, especially into pediatric oncology financing, as my colleagues have rightly said, and also advocacy into medicines availability and accessibility due to just the nature of the shortage of medicines which are normally used for pediatric oncology patients only. So I think with that, I've come to the end of the presentation. Thank you.
Thank you very much, Dr. Wata. Thank you once again to all the participants. So I can see we have close to 1,000. That's very good. It shows our commitment to caring for children. So we have a few questions that we have in the Q&A section. So I'll just direct them to the various presenters. So the first one we have is to Jennifer. What is your experience on the emotional trauma coping of staff working with children suffering with cancer?
Thank you. It's really a challenge because all of us, we are human. And sometimes when we drain emotionally, because from the beginning, when this child comes with a diagnosis, sometimes you see, this child is the age of my child, this child has behaves like my child. Sometimes we take it so personal until we find us, we nurse them as we cry, as we do, as emotionally everybody gets really drained. But our coping skills, just in the morning before even receiving a report from the night staffs, we meet as staff. Sometimes we talk about it over and over again. Those who are more drained, we support one another. We always talk about it. And when we find one of us is beyond, or all of us were drained, we normally call the office of the staff support office. They normally come to our aid, they come to the ward, they do group therapy. Sometimes we go to their office as individuals for the therapy until we cope, because this one keeps us moving on.
Okay.
Thank you.
Thank you very much. I can see there's a suggestion to have somebody who's trained in all staff working in the unit to have some basic counseling skills, which I think we agree with. We have an anonymous attendee asking the following, and I think perhaps Dr. Njuguna can take this one. How do you differentiate between tuberculosis and cancer, considering the signs and symptoms are similar?
Thank you for the question. So for TB, I think we always have to go back to the history and think about exposure, because for children, that is always important. Have they been in contact with somebody who is coughing a long time, or somebody who has been diagnosed with TB? And then when you look at, for example, if they're presenting with the lymph nodes, both in TB and cancer, that can happen. That is why it is important, for example, to take lymph node biopsies in those cases and then confirm whether it is cancer or it's TB. And also, as I said, if you are working in an area where it's not possible to get a biopsy, if you started somebody on treatment and 2 to 3 weeks down the line, there's not much improvement, then that's high time to refer a patient. It's not always easy to differentiate the two on a clinical basis. You sometimes need the histology to be able to differentiate the two.
I think the important thing is to pick that there is something that's going on that's not quite right with the child and investigate it further. And so that you can rule in or rule out whichever diagnosis you're going to get. So we have something that I'm not quite sure what the question is, but I'll combine it with another question. So I think this will be taken by Dr. Chepchumba. What measures are we now putting to ensure that children get screened earlier to avoid more deaths? Because many get screened in late stages. And somebody else is saying that there's a failure to go for the referrals, the congestion of the referral centers. So I think the question is, how are we empowering the county facilities and sub-county facilities to manage these patients?
Okay, thank you for that. From my consultation with the pediatric oncologists, and even Dr. Njuguna mentioned, there's no screening for pediatric cancers like the adult cancers. But what he has mentioned is that we watch out for certain patterns. And if you do some blood work, you can actually see the elevated levels of maybe the WBCs, maybe the platelets will be lower. So it's mostly about being keen on the pattern that you will see on a full hemogram to now see there could be more to this story. I think maybe Dr. Njuguna can add, is there a screening for these cancers?
Well, as we said, for pediatric cancers, we don't do on screening. There are almost no clinical or early things that you can check for to be able to pick the cancer before it starts growing. But what we need to look out for is these early warning signs as we mentioned. And, you know, if you have fever that has been there for more than 2 weeks, you know, start thinking otherwise. If you have this patient who is having these headaches and vomiting in the morning for, you know, the past 2 to 3 weeks, it's high time we started thinking about something else. And this is what we want the people in, you know, the public, the people who are working in the community, the people who are working in the primary and secondary health facilities to be able to pick up and then know where to refer the patients. As it is now, I think we need to create these centers of excellence, which can then be the ones to treat. As has been mentioned, the treatment for children cancer is not sometimes it is and straightforward. So I think it's better when we put the expertise together in a few centers within the country, and then the patients are referred to these facilities. And then these centers can have a shared care network where, you know, if the patient needs to get a blood transfusion and they are away, and then they can access a hospital near home for that. But the main treatment plan needs to be outlined from the main treatment centers.
Okay. So
maybe, sorry, Dr. Irene, can I add
continue.
something?
Sure,
Yes,
sure.
so yes, we have the National Cancer Screening Guidelines, and maybe that will maybe also guide on this topic of screening and early detection for childhood cancers. So I would encourage the team to just go to the MOH website under resources and downloads. There's the book for National Cancer Screening Guidelines, and it has some pointers on the childhood cancers. Thank you.
Okay, thank you. So just to reiterate, we to go to the Ministry of Health website to check for the screening guidelines for Kenya. We have a question that's quite interesting here. I think any of the speakers can take it. Do we have a registry for the childhood tumors at the moment? And if there is, how can we get this?
Well, I can make a contribution, and just to say that we do not have, for example, a registry that is not specific to children, but I think starting probably last year, I think the National Cancer Institute is now stepping this up. And I think from the act that set up the National Cancer Institute, all of us are supposed to report cancers to this institute. And we hope then in the next coming years, we'll be able to have a comprehensive data for the whole country.
Dr. Njuguna, if you could just put in where you said that people should report their cancers in the chat so that people can get it clearly.
What I was saying is that the National Cancer Institute has been given the mandate by the Act of Law to be collecting information on all malignancies that are diagnosed in the country. And okay. I think I've seen them stepping up to this from last year. I think they've been sending out information to facilities that they need to start reporting on the malignancies that they diagnose within their facilities. So I'm hopeful in the coming years, we'll probably have a comprehensive data set for the whole country.
Okay, thank you. So I think the next question is to Dr. Wata. Is it possible to streamline the process of getting chemotherapy drugs? I don't know for inpatients at KNH. I think in general, if you could just comment on what are the challenges you probably face in dealing with drugs for pediatrics so that we have a more holistic view for those who are not in KNH. Dr. Wata.
Okay, thanks. I also I didn't understand that question, but in terms of the chemotherapy process, because we have an inpatient oncology pharmacy which does the preparation for all chemotherapy for all inpatients. And there are several wards that do ordering for chemotherapy. So what we normally do is that we schedule the chemotherapies. So the first thing that we do, there are those wards that are that normally have the many patients. One is GFD, the other one is 8C in terms of adults. Then there's 3D and 1E in terms of pediatrics. Then there's also 1B, the GAIN-ONC, and there's the I ward that treats retinoblastoma. And once in a while, you'll have one of the surgical wards when they have a prostate cancer patient. So what we do, there are clinical pharmacists who will round in the clinics when they're admitting. So when they're admitting for HC, when they're admitting for GFD, and so they will get the chemotherapy summary for all those patients. And also for the pediatrics, we'll do the rounds in the wards in 1E and in 3D. So we'll get the summaries for the patients. And then we will schedule the patients now according to the workload. So we'll know that, for example, we'll schedule some patients for Monday, for Tuesday, for Wednesday, for Thursday, for Friday. So depending on the need and the scheduling, and of course, when we get the particular order. So for 1B and the I ward, we'll wait for them to bring in the files, and then we'll review. If there are any questions, we'll call the doctors in the ward to confirm the prescription, and then now we'll schedule the chemotherapy after we finalized the verification of the chemotherapy. So that is basically the process, and all chemotherapy preparation has to follow that process. Once in a while, we get orders from wards. For example, some wards treating renal conditions, and they require some chemotherapy medicines. For example, treating some of the renal diseases, they use cyclophosphamide or rituximab. And so for them, that since they're not used to that process, they may find it a bit cumbersome, because when they order from the other pharmacies, it's not the way they are not asked for the requirements which we normally ask for the oncology patient. So in a nutshell, that is basically the chemotherapy process. So for the person asking the question, probably they can come to the inpatient oncology pharmacy, and then they can ask the specific question. Then we'll get them on how we can go through that process seamlessly.
Okay, so I think that's the number of questions that we can take, because there are still questions coming in, and the time is almost up. So I would like to thank the speakers for coming on here today on this day of we are talking about childhood cancers, for giving us their perspectives, which are all interesting and unique. And I think the takeaway message that we can get is that the healthcare workers, it's upon us, all cadres, to raise awareness, to have a high index of suspicion, as well as reduce the delay as much as we can within our healthcare system, because we've seen that that's the largest proportion of the delay that patients suffer. So we should also refer to and read more on the WHO Global Initiative for Childhood Cancer. So thank you all for attending this webinar. Thank you for the presenters, and we'll see you next week with the next in the next webinar. Thank you and have a good evening.